Alright guys, so this is the third video in the Gastro series. Make sure that when you learn this, again, start from the beginning. Those retroperitoneal structures, work your way through the difficulty swallowing, and now you're in the stomach, and we'll learn about the proton pump and such. So make sure it's the easiest way to do it is to make sure you tell the story and to pretend like you're going to teach it to somebody behind you. So do me a favor, hit subscribe. It does really kind of help, and hope you like the video. Alright guys, so question number 1 reads, a 75-year-old man with 6-year history of pernicious anemia develops a gastric ulcer on the lesser curvature of the stomach. Biopsy reveals adenocarcinoma. Microscopic examination of the gastric mucosa would likely reveal impairment of which of the following. So the guy's got an ulcer, got this adenocarcinoma, so something's been kind of eating away at this. So to understand these questions when it comes to the GI in the stomach, you gotta understand the basics of the proton pump. Okay, so we initially talked in the last time about the like the esophagus, and we know that the cells that line this, just as a brief review, is going to be the squamous, right? It's going to be the stratified squamous. And then if these things get too much acid on them for whatever reason, then they turn into, in a bad way, the columnar, all right? Columnar cells. So anyways, that takes us into the stomach, okay? Into the stomach, and so if we were to look, if we were to just try to draw it like this, per se, and if we were to kind of take like a section and kind of blow it up, then we can really understand how the stomach works when it comes to, the pH and how it makes its acid and such. And so pH, usually looking at between 1 and 2, somewhere in there. So, but it's the cells where you really have to understand, okay? And if you're looking at the cells here, again, this is just kind of a blown up section through this, and you can say. You can have the mucosal cells, you can have parietal, okay? You can have G-cell, and then you got D-cell. So think about this, you're in the GI, we already talked about the some of the retroperitoneal structures, we talked about dysphagia, now we're kind of moving into the stomach, and you have to understand this as far as the mechanisms to answer these types of questions. So the main cell that we're going to be playing with here is going to be the parietal cell, okay? The parietal cells is where this proton, proton pump's gonna be, and at the end of the day, it's got all these arrows going every which way, but it's going to spit, it's going to spit the hydrogen out, and it's going to spit the chloride ion out, and of course that's HCl, and there, there's your acid. And then it plays around with potassium right there. But the main guys you got to know is that you're in the parietal cell. This is the proton pump, and it's going to make your acid. Now, you say, well, how does this get activated? Well, when you start to eat, there's kind of like this, just basically an anticipation of food kind of coming down the pipe. That's what kind of activates, gets these things going. But there's 3 triggers that actually activate, and this is how I kind of put these little markers on there. There's 3 things that are going to activate the parietal cell, aka activate the proton pump. Now, one of them, well, let me see the best way to do this. Well, let's just go through this with the parietal cell first. So at the parietal cell, you also got to know that there's intrinsic factor, okay? And it's the intrinsic factor is where you're going to be dealing with the B12, okay? So anyways, so now how do we activate this parietal cell again? Well, you can activate it with acetylcholine, and you say, well, where does that come from? Well, it's going to come from the vagus nerve, okay? So the vagus nerve is going to go down here, and then when the vagus nerve is activated, he's going to release acetylcholine, and he's going to come over, boom, activate the parietal cell, and you can get a little bit of acid. The other thing you have to know, and of course I learned all this from mainly Pathoma, is the the enterochromaffin cell. Okay, enterochromaffin cell. This guy, when he's activated, okay, when he's activated, he's going to release histamine. Okay, he's going to release histamine. Histamine's going to come over here and activate that guy, which is going to activate the parietal cell. So here's histamine. Now you say, well, wait a second. Well, what activated this guy? Well, when you released acetylcholine, not only did he come right there on the parietal cell, but then he came over here on the enterochromaffin cell, and when it activated the enterochromaffin cell, it released histamine, which kind of gave like a little bit of a backup there, right? A backup to the parietal cell being active. And then the last one here, well, not one of the last ones, but it's just one of them, is the G cell, okay? Now, you're going to associate this G cell with this Zollinger-Ellison, okay? Zollinger-Ellison, where there's just like a perpetual kind of release or a perpetual activation per se. So, but the G cell, okay, will secrete gastrin. Okay, it secretes gastrin into the bloodstream, and then that gastrin, okay, we'll just say G, the gastrin can come over here, can activate the enterochromaffin cell, which will do what? It'll release histamine, and histamine comes over, activates it, but then that gastrin also has his own little spot to go to on the parietal cell. Okay, so right now we said, well, look, we got to activate this parietal cell or the proton pump. How do we do it? Well, one of three ways. We can either secrete gastrin from the G cell, boom, right? Starts it here. We can secrete acetylcholine from the vagus nerve. It'll activate it right here. And then as a backup, you can activate it with histamine from who? The enterochromaffin cell. Well, how do I activate him? Well, the vagus nerve acetylcholine activates him, and then the gastrin from the G cell activates him too. And then he spits out his histamine. So you can see there's three things there. Now, the D cell, we're going to associate him with somatostatin. Okay? So you have to be able to tell this story, okay? And this is very, very important because it's the mechanism. Again, step one is all about the mechanism. It's the understanding of what's behind it. Okay. So, with that being said, back to the question. It says, 75-year-old man, 6-year history, pernicious anemia. Okay, well, pernicious anemia, what are you thinking? Okay, I'm kind of thinking B12 a little bit there. Develops a gastric ulcer. Okay, well, something's not kind of working there per se, or something's malfunctioning, adenocarcinoma. So this guy is getting, too much activation. And so, basically they're just saying which cell is the one that has too much activation. And out of these choices, the one that has the proton pump is going to be the parietal cell. Okay? But you got to know this. I'd say, make sure you understand that. Can't stress that enough. All right. This one says, 28-year-old in the ICU after a multi-vehicle collision. On physical exam, the patient does not respond to command, has multiple rib fractures and injuries in his abdomen and face. He is intubated and started on sedation while being mechanically ventilated. In the intensive care unit, the first-year resident starts the patient on pantoprazole in anticipation of the prolonged mechanical ventilation. However, the pharmacist requests consideration of famotidine. Okay, notice the difference between these two. The pharmacist requests the switch to famotidine is based on which of the following. So this goes back to having an understanding of the difference between the proton pump inhibitor and kind of like an antihistamine, the famotidines, the ranitidines of the world. So here's how we do it, or a histamine blocker, I should say like that. Is like, well, we go back to, what do we say that the parietal cell, if this was a parietal cell, and, we're going to do the proton pump and get our acid, right? If we get our acid from that, who do we say activates him? Oh, we had gastrin, we had histamine, and then we had acetylcholine. Now, if you use a azole, okay, or a proton pump inhibitor, what gets shut down? the whole thing, right? If you use a proton pump inhibitor, the whole thing gets shut down. Boom, nothing. If you were to use famotidine, or as you would say, a histamine blocker, what gets shut down? Do all three of these things get shut? Does this all not work? No, just the antihistamine doesn't work. So it's like saying, hey, look, we're going to let you produce a little bit of this acid, but we're not going to let you go full force into it. So that's why this guy is a bit of a milder form of reducing this, and that's why it's more of a first line, because there's a purpose. There's a purpose for having this kind of releasing the acid in the stomach, so it goes down and actually protects you. The question is, what does it protect? Now, the learning point from this goes back to this guy, but this makes for a nice little question. Is it A, again, the switch from the azole to the famotidine? Is it hypermagnesium with prolonged use of proton pump? Is it increased risk of Zollinger-Ellison syndrome? Is it increased absorption of calcium with prolonged use of PPI? Or is it increased risk of C. diff infection? Well, if you use a PPI for a long time, you're not going to get hypermagnesium. It's actually going to be hypo. So I'm going to eliminate him. Is it increased risk of Zollinger-Ellison? Well, wait a second. The Zollinger-Ellison had nothing to do with the parietal cell and the proton pump. This was more all about the gastrin from the G-cell. It's secretion of gastrin. It's usually by the duodenal or pancreatic, neuroendocrine tumors for the most part, or they call it gastrinoma. Okay, but long story short, that the switching, basically having a proton pump inhibitor is not going to put you at increased risk, according to that. Is it increased absorption of calcium with prolonged use? No, it's going to actually be decreased. It'd be decreased risk. The correct answer is going to be increased risk of C. diff infection, because we need, if you knock out the proton pump, if you knock out the whole system, you're not going to be getting this guy. At least with the histamine blocker, you're only knocking out one of the three channels, and you're still going to get a little bit of this guy, and that's what's going to protect from C. diff. So when you're learning these mechanisms and stuff, you can kind of understand it and actually apply this, so it's a little bit easier to remember. Okay? So the correct answer on that one is going to be answer choice D. Okay? And I would say, yeah, answer choice D. This one says, a 52-year-old man presents to the physician because of a 14-month history of multiple issues of shortness of breath, fatigue, ringing in his ears, sore tongue, abdominal discomfort, mild peripheral weakness, burning sensation in his hands, and tingling in his toes. He appears thin and pale. So this guy's got this numbness, this tingling, burning in the hands. Hemoglobin's 10, hematocrit's 41, leukocytes are there, retic count 2%. Electrophoresis is normal, okay? So you kind of rule out like thalassemia per se. Blood smear shows ovoid macrocytic, macro, large, okay, of the erythrocytes. So, just right there, macrocytic erythrocyte, you're thinking kind of like MCV level, right? So, if you can have normal, you can have small, or you can have the big. And when you think big MCV, where say it's over, over 100, what are you thinking? B12 or folate, okay? He reports that he follows an adequate diet. His condition is most likely caused by dysfunction of synthetic activities of which of the following types of cells. So it's not like he's not, when he's having a good diet, in the American diet, it's hard to be deficient in a lot of stuff. But if he has an adequate diet, in theory, he should be getting this stuff, but he's not. So it kind of lets us know that there's an issue with kind of, say, absorbing, per se, the B12 or the folate. And so we know that if you have an issue of some type of stomach, what did we say? His condition is most likely caused by dysfunction of synthetic activities, which of the following type of cells? Is it follicular cells of the thyroid, hepatocytes, macrophages, parietal cells of the stomach, or Schwann cells of the coronary artery? I mean, this is like a no-brainer, right? I mean, number one, we're in the GI system, and we're not going to be talking about this other stuff. But number two, we know it's the parietal cells, right? Parietal cells, proton pump, has my H, has my chloride, makes my acid, but it also has my intrinsic factor, okay? And then that's my guy that's going to use B12. And if this guy's dysfunctional, if the parietal cell is dysfunctional, I'm not going to get my B12. I'm going to have my macrocytic. I mean, everything else kind of smoke and mirrors. There's a lot of symptoms, but a lot of times these symptoms aren't really pathognomonic of something specific. They're general. You got to put all these clues together, and that's what's going to lead you to the parietal cell. Okay, and kind of back. Well, now I was going to say back to that. The proton pump inhibitors, or your proton pump inhibitors, they're the ones that end in azoles, and then your histamine blockers, and that's going to be like your ranitidine, cimetidine, and then you got to watch out P450 on that guy. Okay, right? So okay, and let's see. Let's go to the last one. It says, 45-year-old male presents to the clinic complaining of upper abdominal pain. He reports he has significant stress at work and smokes 2 packs of cigarettes every day. The pain occurs between meals and is worse at night and often wakes him up from sleep. He's vomited blood on occasion. Testing reveals a basal acid output of 60 milliequivalents, where the normal, normally it's less than 5, and he's got all this acid, okay? And serum gastrin level of 1,000 when normal is less than 300. Which the following is most associated with his condition? So we have this perpetual release of gastrin, and what do we say? The gastrin. I mean, this is kind of a no-brainer, right? They're saying we got too much gastrin, and gastrin comes from the G cell, right? No need to put a lot of effort or thought into that. Mucosal cell helps to protect. Parietal cell, I think intrinsic factor, and I think the proton pump, right? And then of course intrinsic. There's no intrinsic cell; it's the intrinsic factor. So that's just more of a distractor. And then chief cell. We're probably getting into this into the next video. That has the pepsinogen, which plant that seed. This is an inactive. Pepsinogen is an inactive enzyme. Must be activated. So pepsinogen is inactive. It must be activated by cleavage, and it's the low pH. How I say converts the inactive pepsinogen. As you can guess, it takes pepsinogen, or ogen means to make, to active pepsin. Okay, makes pepsin, and then that starts protein digestion, and that'll kind of lead us into our next topic. But anyways, that's the chief cell. Okay, that's the chief cell. Pepsinogen, inactive, must be cleaved through a low pH, makes pepsin, starts protein digestion. So very, very important. But back to this one, if they give you something, if you got gastrin, you better just know the G cell. So again, you just have to tell that story. I mean, if there's nothing else, you should be able to start with the retroperitoneal structures. I mean, I guess you could almost do it like this. Retroperitoneal structures. Remember, the kids eat pancakes. They go up the hill, down the hill. They get scared. Aorta, and then the adrenal gland, inferior vena cava, which is the cave, and the pancakes kick in. They go to the bathroom. Kidney, ureter, rectum, and duodenum. We talked about the dysphasias. Achalasia is the one we said you better know, pretty solid. Achalasia, and compare it with scleroderma. One has high tone in the lower esophageal sphincter. One has atrophy, which is obviously is loose. With the achalasia, Trempeziano cruzi, bird's beak, ganglion cells, but it's the ganglion cells of the myenteric plexus. Okay, myenteric plexus. And then again, Barrett's esophagus, like we talked about, where it kind of gets spewed up. Normally, you should have the stratified squamous, but it gets replaced by the columnar epithelium right here. And so now we're making our way kind of down into the stomach, and then this is where we'll have our basically our parietal cell, G cell, D cell, and mucosa. Make sure you understand the mechanism, and then we'll kind of keep moving our way through this. So hope the video was helpful.